Hello, this is Anthony, and today I will be introducing OB concepts. We suggest that you get out a piece of paper so you can jot your questions as they come up. That way, you can post them in the student forum or you'll have them handy for our next class meeting. So, you need to pause the video, go grab a piece of paper and a pencil or pen, and we'll get started. We will be discussing the OB nurse, the history of childbirth, where we are, where we hope to be, and the issue of access to care, specifically as it pertains to the OB patient. Let's start with the role of the OB nurse. The OB cares for the woman during various periods of her childbearing age. The prenatal period is clinic-based care, and the nurse will assist providers, being midwives and doctors, in the assessment of the pregnant woman and provide education to the pregnant woman about what is expected and what warning signs she should look out for. And the nurse cares for the pregnant woman who is experiencing complications. This could be outpatient in the form of antenatal testing or inpatient if the condition or the baby necessitates an inpatient stay. The intrapartum nurse cares for the woman and of labor. The postpartum nurse cares for the patient in the period after the delivery of the baby to ensure the newborn is effectively transitioning to extrauterine life and that the woman is safely transitioning to the post pregnancy state. Home visits are a great way to assess how the family is transitioning to life with a new baby and to help provide support to the family in their home environment. The OB nurse is responsible for care and education of the pregnant postpartum woman, including self care, newborn care, and breastfeeding support. Childbirth has changed drastically over the years. In the 1700s, home births were attended by midwives. In the 1800s, there was a shift from using midwives to doctors among middle class women. In the early 1900s, we saw drug induced twilight sleep, um, which was done in the hospital. This is birth practices in the hospital. And we saw lots of nurseries created to care for the newborns. So once the baby was born, the baby was whisked away to the nursery so that mom could rest. The 1970s saw a pendulum swing and growing trends to return to the non medicated, non interventive childbirth. Early 2000s, 1 in 3 women undergoes a surgical birth, also known as a cesarean section. We see a variety of childbirth classes available in most communities. Current initiatives to decrease primary C-section rates and to accommodate the woman in her wishes. We're moving more and more towards evidence-based and family-centered care. We have come a long way from the colonial America time where 50% of women and baby died in childbirth. We have a long way to go to ensure the safety of every woman in childbirth, but we are doing much now. So I want you to take a few minutes to jot down your key takeaways regarding the OB nurse and the history of childbirth. Don't worry, there's no right or wrong answer. We're just going to type in what you think the key takeaways from the last few slides were. So the OB nurse is responsible for the care of the pregnant woman throughout the various stages of her pregnancy and for the newborn baby. From a childbirth perspective, colonial America, childbirth was difficult and dangerous. In the early 1900s, we had some physician assisted births. We were utilizing twilight sleep and some midwives. The 1950s to through the 1970s and on, we had an introduction of natural childbirth practices. And now we have the midwives and doulas, childbirth choices. However, our mortality rates are still high, much higher than we would like them to be. So, in care, there are a few core concepts to consider when we look at improving the care that we are able to provide to our patient. In looking at evidence based care within the context of the family unit, we want to ensure there is evidence to support the interventions we are utilizing and that we involve in the decision making process. Interdisciplinary care improves outcomes because it involves the various disciplines in the planning. So, all the disciplines that are involved in the patient care are working in conjunction with one another, as opposed to in silos or even potentially worse, working against one another. Processes such as interdisciplinary rounds, where the various disciplines all round together, helps to ensure the plan of care includes all disciplines and that there aren't any gaps in the care the patient is receiving. We will be expanding family centered care, evidence based care, and case managed care in the next few slides. We will also take a look at the Healthy People 2030 goals, specifically how pertain to us maternal child health. So, what are some of the concepts related to family centered care? Family centered care is an important in all aspects of nursing, really has a special place in maternal child health. Just looking at it from a high level, in, in OB, the entire family is impacted by the addition of a newborn. And in pediatrics, the family is oftentimes we as nurses are communicating with and who is making the decision, the care the patient is receiving. Some key concepts that we want to remember are that childbirth process. The majority of women who give birth are not sick. A woman is meant to grow and give birth to a baby. Pregnancy and childbirth impact the entire family. We as nurses want to involve the entire family in the care. Admits visitation restrictions related to COVID. Hospitals recognize the important role that the family plays in the childbirth process. Most hospitals are allowing one visitor to be with the patient who is giving birth, and one visitor to be with patients, and one visitor to be with NICU patients. To empower families to make decisions related to their work by giving them adequate information and professional support. If we run into situations where families are declining standard interventions, we as the nurse will want to explore why and what information they are basing their decision on. It's important to do so in a respectful manner without belittling the patient or the family. A few weeks ago, I was in triage and I had a patient was taking care of a patient who had been admitted for labor, but we were so busy that we didn't have any labor beds available for that patient at that time. She desired a natural childbirth, so wasn't requesting an epidural at the time. It was her first baby, and her husband and the patient kept asking when they would get a room. And unfortunately, they the totem pole to get a room because she was stable. She didn't want an epidural. And we were able to provide the needed care to her in the treat room. We had a number of unstable patients that needed the labor room first. So I explained to the family and or to the husband and the patient that it was probably going to be a little while. And they asked for some oxygen. And I said, well, we don't provide oxygen. Um, but what do you want oxygen for? Do you feel like you can't breathe? And she said, no, I'm breathing just fine. I said, okay, would you like me to take your O2 saturation to determine if you need oxygen? She said, no, I don't need to eat for breathing. I want it for pain relief. And I looked at her kind of quizzically, I'm sure, and said, okay, well, tell me more about that. Why do you think oxygen is going to help you with your contraction pain? Said, well, my cousin got it when she was in labor and said that it helped her a lot. So we kind of had to hash out the fact that oxygen is not used as a pain control medication, and that one, with COVID, we don't give oxygen to moms unless it's indicated for the maternal oxygenation status. And two, we oxygen is a drug. We can't just provide oxygen at a whim. So it was interesting in my many years of practice. That was the first time I had heard that one. But I needed to explore it with the patient and her husband as opposed to just dismissing them so that they would respect what I was saying and wouldn't feel belittled. So we got through it and I got her a bed and she was happy as a clam once she got into that bigger room. So that we always want to know where a family is coming from and address it with the evidence that we have to support what we are telling them. So, evidence based nursing practice. Not the first time in your career as a student that you're hearing the phrase as evidence based nursing practice. In the past few years, we have finally started to see a significant shift in OB practices to follow the evidence as opposed to doing something just because that's the way we've always been. A great example is the use of oxygen for the resuscitation of the baby during labor. I just mentioned that using oxygen anymore, unless there's a maternal indication. But for years, we have provided O2 to mom via either a night breather or a simple mask at 10 liters a minute to help improve the fetal status if there was signs of fetal compromise. However, there's never been any evidence to support the use of O2. Any delivery nurse will tell you that we see an improvement in the fetal strip when mom on OT. Evidence does not support any improved outcome for the newborn. So with COVID, we've now stopped using O2 for fetal resuscitation and only use it if it's indicated based off maternal saturation. Evidence-based nursing practice problems approach to making nursing clinical decisions and involves the collection, interpretation, and integration of validated research derived evidence from a variety of sources. So we're going to use plans that are research based. We're going to come at things with a problem solving approach, and we're going to hopefully have practices and have policies and procedures that are based off of the current evidence. Case managed care is a collaborative process. It involves the assessment, planning, application, coordination, follow, and evaluation of clients' health needs. It allows for effective advocacy since each patient's care is looked at by the individual managing the case. That person, the case manager, will have a holistic view of the patient as opposed to look at the patient from just shift and discipline to discipline. It allows for seamless care across the continuum. All practitioners will have information related to the patient, and it lends to interdisciplinary approach. By taking a case managed care approach, patients are more likely to receive the appropriate care at the right time based off of their history and their current condition. So we improve patient outcomes by taking a case managed care approach. So I mentioned earlier that we still have quite a ways to go with our mortality rates. And unfortunately, even with all of our medical advances, women are still dying in childbirth and due to childbirth. Of the 700 deaths that occur each year in the US, more than 50% of those are preventable. Women of color are 2 to 3 times more likely to die. Statistic has a few different reasons behind it. Women of color are more likely to have complications of pregnancy, such as diabetes, preeclampsia, and obesity, all which put her at a higher risk of having significant complications up to and including death. In addition, bias continues to increase the death rate for color. I recently did a training through Kaiser that told a story about a woman who due to internal bleeding after childbirth. Both the patient and her husband were Black, and the nurse in the story interpreted the patient's reports of pain as cultural and therefore not as bad as she was reporting them. And the nurse interpreted the husband's advocacy for his wife as aggression. Unfortunately, this was a true story, and the patient did die because her bleeding was not time. As nurses, our various experiences add to our knowledge and help us to become better nurses and better practitioners. However, it's so important that we don't apply personal attributes of one patient onto another patient in our assessments. Applying what we see in one assessment to a patient in a next assessment could be very helpful because we can see that X leads to Y. However, the personal attributes need to stay out of our assessments, our physical assessments. There are many different initiatives to reduce the mortality rate associated with childbirth here in the US. One of those is something you've also probably heard in your nursing student career, the Healthy People Goals. So Healthy People, it's now 2030 because we have retired the 2020 goals. So Healthy People 2030 has many goals that are related specific to maternal child health. So at this point, I would actually like you to pause the video. You're going to have to go into the PowerPoint itself, the PowerPoint file, and put it in present mode and click on that Healthy People 2030 icon there, the picture. And take a look at some of the Healthy People goals as they relate to maternal child health. That should link you directly to the maternal child health page. Just come back and hit play when you're done. So take a moment and type in your key takeaways from the last point that we did, key takeaways. So improving outcomes. Interdisciplinary evidence-based care from a family-focused perspective improves our outcomes. And Healthy People 2030, some of the key goals there to reduce maternal deaths, reduce preterm births, reduce or lower the low risk C-section rate, so reduce the low risk C-section rate, reduce illicit drug use. And as I'm sure you saw on the website, there are plenty more where that came. Okay, so now we're going to take a look at the factors that impact maternal and women's health. We'll dive into a few of these in the next slides. Family is going to have an impact on the health due to the family belief system, the family structure, the family support that's available. So, moving on to genetics. Genetics involves the study of heredity, which is important in OB nursing because it's something our patients will be thinking about. They want to know what that little baby grown inside them has, right? There are many diseases that are passed on genetically or genetically based. Some are commonly tested for in a adult period, such as the various trisomies. For instance, trisomy 21 is Down syndrome. And cystic fibrosis is also tested for in the prenatal period. And some genetic diseases are discovered after birth. There is a specialty area called genetic counseling. Some genetic counselors are nurses, some are just a special in that field. Parents can utilize the genetic counseling if their baby is at risk for having a genetic disease. An important concept to remember is that each pregnancy is a new and unique event, and the genetic makeup of each child is different. Therefore, the outcome of one pregnancy does not predict the outcome of the next. For example, there's a 50-50 chance of having a boy with each pregnancy, regardless of how many boys or girls the family already has. Similarly, there are certain genetic diseases that are more common in one gender over another, such as hemophilia is more common in males, and certain diseases that are more common in specific races, such as sickle cell anemia is more common in African Americans. So genetics is something to consider and something to be able to answer basic questions about from in the prenatal period, and to be aware of that we might see in the labor and delivery area preparing for difficult births or a known birth that's incompatible with life, or even being ready for those on situations where there's some sort of genetic abnormality that's visible in a parent once the baby is born. Society impacts maternal and women's health in a variety of different ways, from the social roles that women play to socioeconomic status, which can include challenges related to poverty, homelessness, and violence. Community healthcare is important to overcome some of these discrepancies, and we need to be aware of the global health considerations for women as well. Domestic violence is a particular concern with the pregnant woman as rates of domestic violence increase in the pregnant population. RADAR is a good acronym related to domestic violence. So R is routinely screen every client for abuse. A is affirm feelings and assess the abuse. D is document your findings. A is assess for your client's safety. And R is review options and make referrals. Many hospitals have a screening tool that is utilized in triage. Woman comes into the hospital. It's a good time to capture her, as most of the time we can get the woman alone or make it a part of a screening tool that they fill out specifically when they're in the bathroom. We don't want to ask domestic violence questions in front of the significant other. If for some reason we're unable to get the woman alone, we will wait until we have an excuse to ask the significant other to leave the room. And then we'll ask those questions at that point in time. Health status and lifestyle can also impact maternal and women's health. The developmental level of the individual is going to have an impact on how well she is able to care for herself, how well she is able to understand the needs that her body has, and if she's pregnant, the needs that her baby has. Nutrition during pregnancy and at all times is of utmost importance. And so, if we have a healthy lifestyle, we're going to have a healthier woman. A woman who is eating fast food every day is not going to be quite as healthy. And we all are pretty aware of the impact nutrition can have. One thing we also want to keep in mind is from a newborn perspective, the nutrition that a child or baby and a child receive can impact their development as well. So, if a child is not receiving adequate nutrition, then they are not going to develop at the same rate as a child who is receiving adequate nutrition. Lifestyle choices such as smoking, promiscuity, using the gym are all going to impact the health of both maternal health and of women's health. We also want to consider environmental exposures. So, where does this woman live? Where does she work? Is there something that she's exposed to on a regular basis that's going to impact her health? And then stress and coping. Anytime we can, we want to assess the coping mechanisms that our patients have. In fact, it's actually become part of a standard triage assessment and a standard head to toe assessment in most hospitals, because we want to make sure that everybody has some way to cope, especially with our current environment and how much stress there is in everyday life for almost everybody. Having adequate coping mechanisms is important to be able to get through that. Can think about your coping mechanisms. Nursing school is incredibly stressful, right? So, what are your coping mechanisms? The cost of healthcare can directly relate to whether or not someone is going to receive care, or whether or not they're willing to go receive care. We see many women who don't receive care due to the cost or because they're waiting for Medi-Cal approvals. We know that consistent prenatal care improves outcomes, and therefore we need to ensure that individuals know about the fabulous free options we have available and know how to obtain the state issued insurance. Healthcare costs can contribute to the quality of the care that is received from a couple different perspectives. One, you could have a doctor who's more expensive because he is more um, experienced. It could also be from the perspective of consistency of care. So, if I am consistently receiving care, the quality of care that I receive is going to be better because the practitioners have a better history on me. So, quality of care can come from a few different perspectives when it comes to thinking about healthcare costs. We want to focus on preventative care so that our patients aren't sick, so that we're dealing with healthy people, right? So that we have a healthy society, healthy culture. So a lot of clinics do provide significant preventative measures as well. And then we're going to think back to that care focus. So remember to case managed care, how we're looking at care from a continuum. Bringing down healthcare costs, the continuum of care can help bring them down, because if we catch something earlier, we're going to have an easier time treating it. That leads right into improvement in diagnosis and treatment. A major goal of healthcare is the improvement of diagnosis and treatment. This is a goal for maternal and women's care as well. Only recently have researchers, medical community focused on the special health needs of women, particularly. Oh, I know you all are probably much younger than I am, but I remember when commercials started to come out for what it looked like for a woman to have a heart attack, because a woman's symptoms of having a heart attack are much different than symptoms of having a heart attack. So understanding the differences and that we're not all just the same is a new it's a new development in healthcare, and it's important for women's health that we understand that women express disease differently, they express emotions differently, and they should be treated differently. Everyone has a personal responsibility to to take care of themselves and to seek care when needed. We want the family to participate as much as possible, because the more everyone knows, the more everyone can hold their family members accountable, and we might get a better story. We might get a better history than if it's just coming from one person. And then we always want to show respect for the family's views and concerns. I think we've talked about this pretty extensively. So this one I'm showing you the answer to. So we have continuum of care as our answer. And a continuum of care provides cost effective continuity of care from the acute care setting, such as a hospital, to the outpatient setting, such as rehabilitative units. So, this is really going to help with that. That adequate care and reducing the cost of care. So, what are some common barriers of healthcare or to receiving healthcare? Well, number one is finances. If people don't have the ability to pay for insurance, then they're less likely to go to those yearly, annual preventative care appointments and more likely to show up in the ER with something seriously wrong. Transportation becomes and most hospitals now and a lot of doctors as well have contracted with some of the share ride like Uber and Lyft to bring their patients to and from their appointments or the hospital. Language can be a big barrier as well. Language, if you don't understand your healthcare practitioner is telling you, then you can't implement what's going on. And it is our responsibility as healthcare workers to ensure we are discussing care in their preferred language. So we have some great translation devices now. It used to be two-way telephone, which was a pain in the patootie, but now we have a great program with iPads or even translators who are at the hospital to translate in person. So although language can be a perceived barrier, we should not allow it to be a barrier in our practice. From a cultural perspective, we do need to take different cultures into account when we are caring for patients. You may have heard me tell this story before, but I'm going to tell it. When I was in nursing school, it was my first clinical rotation. We were a few in, and we were on a telemetry floor at Sharp Grossmont. And I was caring for a patient with the nurse I was assigned to, who he was from Iraq, I believe. And I don't recall what he was there for now, but we had it was a really busy day, and a fellow student and I started to kind of focus on this guy because he seemed to be so combative and he seemed to be so uninterested in the care he was receiving. He was in restraints because he had pulled his Foley out. Now, can you imagine pulling Foley out with that bulb blowing up? And he had his IV out. So he bought himself some drinks. He refused to eat and looked distraught. Nobody bothered to get a translator, and we finally asked for a translator, my fellow nursing student and I, because we had been taught you don't try to communicate, you get a translator for all communication. And when we finally got a translator, he didn't have money with him to pay for the service he was experiencing. So in his home to the hospital, you cash for each service you received. So when they put the Foley catheter in, he thought he had to pay for it. When they put the IV in, he thought he had to pay for it. When we brought him a tray of food, he thought he had to pay for that. And he had been there for 2 days at that point and had was now sitting in restraints just due to a misunderstanding of how our hospital system worked here in the US. We got his family there and got him eating, and his complete disposition did a 180. He was just a very pleasant, different gentleman at that point in time. So we always need to consider language and culture when we are caring for our patients. And then healthcare delivery systems, different systems have different requirements, which can lead to certain barriers as well. So here her concerns is a CDC initiative to reduce maternal mortality in the US. We're actually going to work more with this in class when we meet, but if you wanted to take some time and look at it beforehand, I included it here. You'll have to do the same as you did with that Healthy People 2030 slide and put it in present mode to the click on the and it will take you. I think it actually is going to take you to a Google Doc that we'll be working on in class, but the link to the website is in that Google Doc. There's some interesting stories there and videos. So if you have some extra time, which, oh, I'm sure you have all the time in the world on your hands, you can go ahead and look at that beforehand. So take a minute and type in your key takeaways. So there are many factors that impact maternal and women's health care. Some that we talked about today are genetics, society, health status, lifestyle choices, and healthcare costs. We have goals to improve diagnosis and treatment. And some of the barriers to healthcare include finances, transportation, language and culture, and healthcare delivery options. So if you wrote down any questions, feel free to post them in the student forum discussion, or you can just bring them to our next class meeting. I'm sure other students have the same or similar questions, so please don't be afraid to ask them. I hope you have a great rest of your day.